Okay. So in pediatrics, we frequently talk about otitis media, which is infection of the middle ear, but you can also have otitis externa, which is an infection in the ear canal. So from the opening of the ear to where the tympanic membrane is. It's also called swimmer's ear, and pain and tenderness on manipulation of the pinna and the tragus. This is manipulation of the outer part of the ear, causes pain in the ear canal. So the tympanic membrane is normal. Hopefully in your clinicals, you're going to get a chance to look inside the ear canal and look down at the tympanic membrane. It should be like a pearly gray color. When you have an otitis media, it's red and it can be bulging. So in otitis externa, it's normal. You also have to worry about things like, is there like a foreign body or some other sort of infection other than just a straightforward infection of the ear canal. And you can put in topical antibiotics, and you also try to treat people to get all the water out of the ear. Like after they go swimming, that they shake the water out. They don't leave any water in there. That could then be a setup for an infection. And this is now otitis media. So this is the tympanic membrane if there's an infection. So normally, like I said, it's normally like a pearly gray color, and you can see here that it's quite red. And this is what it means by bulging. You can see this kind of sticking out. So otitis media is inflammation of the middle ear. And the eustachian tube helps protect the middle ear, and it provides drainage from the middle ear and equalizes air pressure. And differences between the eustachian tube of infants and young children and older children is one of the main reasons that they're a setup, or they're more likely to get an otitis media. So usually what happens is a child or an infant will have an upper respiratory infection or a cold, and then after that gets better, they develop the otitis media. It can be viral or bacterial, and these are some of the common bacteria that can cause ear infections. And I briefly mentioned this, that their infants are they're more prone to ear infections because of their ear anatomy, and they also have like a lower defense system. They don't have the same immune system as an adult. So you will probably see a kid with an ear infection when you're working in pediatrics, and this picture is pretty indicative of what kids look like when they have an infection. They tend to rub their ears or put their fingers in their ears or roll their head from side to side. If ear infections aren't treated, it can lead to hearing loss or speech problems. Sometimes they end up not being attentive because they're in pain or they can't hear. So it is important that when they have symptoms of ear infections, they get taken in to be seen so they can get started on the appropriate treatment. So you can end up with a chronic otitis media if they end up with the condition that won't go away for 3 months. It's usually treated with antibiotics, but not always. It can be a viral infection. Sometimes they can also treat it with some eardrops, depending on what the doctor feels. You can pull the pinna down and back, and then put the drops in. Like I said, it's most always treated with oral broad spectrum antibiotics. And with kids that have chronic or recurrent ear infections, they might place tubes to help relieve the pressure and help drain the fluid from the middle ear. So one of the main things you do as a nurse is you make sure that your parents understand the instructions for their child. So for ear infections or anytime they're taking an antibiotic, it's really important that they finish the antibiotic course. So if they're prescribed antibiotics for 7 days, the parents give the antibiotics for the full 7 days. They don't stop after day 3 when the kid feels better. And a lot of times
Stop.
Oh. A lot of times kids will feel better right after they get started on their antibiotics. So it's really important that you go ahead and teach them to keep them the entire time, because usually they'll feel better after a couple days. So then sometimes parents think they can stop. So what do you think? Why should they take them for the entire time? What happens if they don't take the entire course of antibiotics?
They build up a resistance.
They build up a resistance. So then it's harder to treat subsequent ear infections. So then they're more of a setup to get recurrent ear infections. Very good. And what do you think the differences are between a kid's eustachian tube and like an adult's eustachian tube? Why would the differences in the eustachian tube set a kid up for an ear infection?
Is it the angle that their ears are? So like you
It's
have to
the
pull
angle
up.
that their ears are, and they're also, it's not as long, right? They're just not as big. So it's shorter and wider and it's flatter. So it doesn't have the same ability to drain the fluid. Very good. So if kids have recurrent ear infections, they can end up with hearing impairment, and kids can also have hearing impairment for other reasons. They are tested, like if you're born in a hospital in the United States, you get tested for an auditory response from your brainstem before you leave the hospital. But if you're seeing problems with learning to speak or behavioral problems, you should still have in the back of your mind that it could be a hearing problem. And you should try to get kids in to be tested for hearing impairments. So if you're a nurse working with a hearing impaired child, one of the most important things to remember is like hearing impairment is not correlate with intelligence. So the child could have a hard time hearing and have normal or above normal intelligence. So never assume that a child that's not able to communicate with you the same way has some sort of an intelligence problem. So do your best to meet the needs of the child, come down at their level, face to face, eye contact, talk in short sentences in case they're reading your lips. And this avoid exaggerated face or lip movements. You don't want to do any of really big movements with your mouth because that can make it harder for them to read your lips and try to figure out what you're saying. So that is the end of the hearing section. We're going to move on to eyes now. So has anyone in the class ever known a kid that had to wear an eye patch?
My sister did and she had surgery.
Okay.
My niece did.
Your niece did? And did they put it on the eye that had the problem or the good eye?
Pretty sure they put it on the good eye.
They put it on the good eye. So strabismus is one of the conditions in pediatrics where they can put an eye patch on to see if it'll work. So if you see a kid that's squinting, covering one eye to see, or tilting the head. So strabismus is when they don't have the muscle coordination of one of their eyes. So they end up with this is his strabismic eye here. I guess it's the one on the left. It's the one that's in the corner. So his eyes, they should be in the middle, and his is over to the corner. So he's not able to, his muscles that move that eye aren't fully developed. So they'll put the patch on the good eye to strengthen the muscles in the bad eye. So a lot of times that works, but someone said they had a child that needed surgery.
Yeah, my sister's daughter needs surgery.
Yeah. So sometimes it kind of depends on, if it's the muscles completely paralyzed, the age that it's diagnosed, if the patch will work or not. So usually, like I said, the first line is to try the patch. If there's also like any sort of visual problems, they can try glasses also. And then the last thing would be surgery. And then there's another condition that's not in here, but it is in pediatrics. Has anyone heard of amblyopia? So that's when the vision is different between the two eyes. And it's the same thing. Like if you have really good vision in your right eye and bad vision in your left eye, they'll patch your right eye to try to make the vision better in your left eye. So those are the two conditions in pediatrics where they'll try patching the eye first, and they put the patch on the good eye to try to make the bad eye stronger, either from a visual impairment or from a muscle standpoint. So sometimes kids will just, not have strabismus, but they're squinting a lot, and they might just need an eye exam. So kids can have visual problems, and they just need to, maybe they just need to wear glasses, but they're not always diagnosed right away. So pay attention to, like, do they have a short attention span? Are they having a hard time learning to read? Are they, not able to see the board? Do they have frequent headaches? Those could all be indications that they need to have their vision checked. Sometimes they can actually have a problem with the eye where there's like inflammation or it's red or something. So just be aware of that, vision, is something that kids can have problems with at a very young age, and they should really be screened if they're having any problems or if they're squinting. So retinoblastoma is a cancer that occurs in childhood, and you'll see it here. It's all of these pictures that have this white light in the retina. So it's the yellowish bright reflex is seen in the pupil, and is accompanied by vision loss, strabismus. Hyphema is going to be a little bit of that, like a little bloody spot in the white part of the eye. And it responds to chemotherapy, etc. But in the worst case scenario, they might actually have to remove the eye. So the main treatment is going to be photocoagulation therapy with a laser, chemotherapy, and they can do irradiation therapy also. And then worst case scenario, they actually have to remove the eye where the tumor is. So something that you should know, like always in nursing, you should know what the medical emergencies are. So you should always be able to identify in a situation if something is a medical emergency. So if you have a patient that has fixed and dilated pupils, that's a medical emergency. So it's an indication that there's buildup of pressure inside the brain, so increased intracranial pressure that's putting pressure on your cranial nerve, and that is preventing your pupils from reacting normally. So, we look at pupils, but in general, when we're talking about neurological problems, we're going to be paying attention to their level of consciousness. So there's a couple of different things that can cause an altered level of consciousness, and some of them are related to your breathing. So a fall in oxygen or a rise in carbon dioxide. So you breathe in oxygen and you breathe out carbon dioxide. So if you're not effectively breathing, either one of these two things can happen. You can also have low blood pressure that causes inadequate brain perfusion. Fever can be associated with altered level of consciousness. For every 1 degree rise in fever, your oxygen needs go up by 10%. So you're going to have increased oxygen consumption, increased oxygen needs if you have a fever, and over time that can lead to an altered level of consciousness. Certain medications can cause you to be altered. It's normal for children or adults to be what's called post-ictal after a seizure. So, excuse me, when they're done having their seizure, they're altered, they're sleepy, they're groggy. And then finally, the thing that's like the biggest emergency that you would have to worry about would be increased intracranial pressure. So this next slide here, it goes over what the 12 cranial nerves are. Coca, hey, Coca. So I can honestly say that you don't need to memorize the 12 cranial nerves, but I would recognize a few. So I would recognize that nerve 8 is the acoustic nerve. I would probably recognize that nerve 12 is the hypoglossal. And so these, and then, yeah. So, the name of the nerve kind of frequently indicates how you would test it. So if you were worried about a nerve 8 cranial nerve problem, then you would test their hearing. Hypoglossal is going to be like their ability to stick their tongue out. Optic is their ability to see. So like I said, there are not test questions that ask you to regurgitate the name of a cranial nerve. I would know that there are 12, and I would recognize the ones that are kind of the most common, like olfactory, optic, acoustic, hypoglossal, and know how to test if those nerves are altered. This is an acronym that helps you remember what the 12 cranial nerves are. So once one takes the anatomy final, a good vacation seems heavenly. And then every letter of the words in that sentences corresponds to a cranial nerve. So there is something called Reye's syndrome. Has anyone heard of Reye's syndrome?
Yes.
What medication? Yeah. What medication is associated with Reye's syndrome?
Aspirin.
Aspirin. And what medication family is aspirin in?
Is it an NSAID?
Yeah, so it's actually in the salicylate family. And the reason why I'm telling you that is because the whole class, aspirin is the most common, but any salicylate could cause Reye's syndrome. So sometimes on tests, you'll see salicylate instead of aspirin. So it causes neurological problems. They become floppy, not able to have like normal muscle tone. So they're just kind of flopped over and weak and vomiting uncontrollably. They can get very, very sick. So, they can have bleeding problems. They can bleed into their brain, which would cause increased intracranial pressure. So there's, if a child has Reye's syndrome, I think it's pretty rare. Most parents know not to give aspirin to their child. So the main thing that you do to prevent Reye's syndrome is not give aspirin when the child has a febrile viral illness or flu-like symptoms. So the basic goal of treatment is supportive care, making sure that you're monitoring their neurological status, making sure they're not showing signs of increased ICP, preparing for intubation. They might need intubation, making sure they're adequately oxygenated and fluid and electrolyte balances. They can have a lot of vomiting, so you need to pay attention to that. So this here in yellow is the name of the medication class, the salicylates. That's the family that aspirin is in. So it's not just aspirin that is associated with Reye syndrome, but aspirin is the most common medication. So it's any medication in that salicylate family. So, to advise parents to read medication labels carefully to make sure there aren't any salicylates in the medication that they're taking. And in this section here, it's mentioned, let's see here on this slide here, reducing ICP. Okay, that's good. But what are some signs of increased intracranial pressure? Like, what would your patient look like if they had increased intracranial pressure? Does anyone know?
Lethargic.
Lethargic. Very good. How about vital sign changes? What might you see in their vital signs if they had increased intracranial pressure?
Would it be low blood pressure?
So
Or low
low
heart
blood
rate?
pressure. Right. Okay. So there's something called Cushing's triad, which is like three vital sign changes that are associated with increased intracranial pressure. And one of them is low heart rate. So low heart rate with high blood pressure and then irregular respirations. So those three things together are concerning for increased ICP. So if you are taking care of a patient that has altered mental status and all of a sudden their blood pressure goes up, that's something that you really need to worry about. It's kind of one of those things as a nurse, you need to be paying attention to, and it's really concerning if the blood pressure goes up and the heart rate goes down. So just to kind of have that in your mind, anytime you're dealing with somebody that has altered mental status or is at risk for altered mental status, the irregular respiration, the low heart rate with a high blood pressure are the things that are concerning that they could have increased intracranial pressure. So meningitis is a infection that can cause altered mental status. It can also cause increased intracranial pressure. So meningitis is just inflammation of the meninges, and who knows what the meninges are?
Isn't it with the brain, the spinal cord?
Yeah,
Like
it's the
fluid?
membrane. It's the membrane that surrounds the brain and the spinal cord. Very good. So it's the whole area can be inflamed. They can be very sick, fever, chills, severe headache, nausea, vomiting. They can have a stiff neck, sensitive to light. Sometimes they're really drowsy, and sometimes they can be a little bit confused. They can have altered mental status when they have meningitis. There's a couple of different tests that they're not definitive for meningitis. Like if they have a positive Brudzinski sign, it's not 100% indicative of meningitis, but it's commonly documented when you are suspicious of meningitis. So Brudzinski's is the one where the kid's lying down in the upper corner. So it's a very stiff neck. So when the kid has a stiff neck, and then when you move the head up, then the knees go up. So it causes the patient's hips and knees to flex, so to move up when you move the head up. So they're lying flat and you move the head up and then their knees go up. And the other one is the Koenig sign, which is the bottom corner of the child here. And when you put their leg up in that 90 degree, they're unable to totally straighten their leg. So both of those are tests that can be done, with a kid, assuming the kid's awake and alert, and you can, if you see either one of those as an indication that they could have meningitis. But they're not definitive. Like, you wouldn't start somebody on antibiotics, not that, as a nurse, you're going to be the one prescribing the antibiotics. You wouldn't necessarily start someone on antibiotics based on that alone, but it is one of the criteria that you can use to help differentiate what might be going on. So what do you think? How do you determine 100% yes, the child has meningitis? What test do you think you do?
A blood test.
You
Or like
will,
a
you will
spinal,
certainly
would it be
do.
a spinal?
Oh, very good. Yes, Cassandra. So how do you test the cerebral spinal fluid?
Is it like an
Spinal tap.
epidural, but like you
Oh,
would reverse it?
very good. Yeah. So it's called the lumbar puncture, but it's the exact same place where you would do an epidural. If you've ever had a baby and they put the needle in your back and then they injected the medication, it's the same spot on your spinal column. But instead of injecting medication, they're going to let some of that fluid come out. And then they send that fluid, it's the cerebral spinal fluid, to the lab. So that's the definitive confirmation of meningitis. So if you are taking care of a patient that has meningitis, they will always be in droplet oscillation for at least 24 hours until you make sure that they're on the appropriate antibiotics. So this means that you'd have to have the cultures back. You would need to know what they were sensitive to, and then maybe they would come off isolation depending on your hospital policy. They are at risk for altered mental status. So you're going to be doing frequent neurological checks and you know, reporting anything like weakness of the limbs, any speech difficulties, mental confusion, anything like that that seems off, you need to report right away. You also have to do, you know, make sure you're doing your vital signs and your eyes and nose accurately, putting them in quickly. And things like noise and light and all that stuff can be really annoying and kind of provoke more pain in a kid that has meningitis. So you want to maintain a quiet, calm environment. So sometimes patients that have meningitis can have seizures. So just to be aware that is possible. And just in the general population, sometimes certain things can provoke seizures. So in addition to meningitis, flashing patterns of light. Sometimes if kids are just being, for whatever reason, there's a light going on and off really close to them that can provoke a seizure, being overly hydrated. And if they're really, really prone, then you sort of startling movements. So seizures, you know, can happen kind of because of an illness like meningitis, or they could have epilepsy, which is this a seizure disorder that's related to like abnormal electrical firing in their brain because they were born with that problem. What other things? What other things might cause someone to have a seizure? Does anyone know? What do you think? Does high blood sugar or low blood pressure, what would be more likely to cause the seizure?
Hypoglycemia.
Hypoglycemia, which is going to be low blood sugar. They can fall and hit their head and they might have a seizure. Certain medications, they could, have a medication reaction where they have a seizure. So just to be aware, most common in kids is probably going to be they have epilepsy. But there are other things that can cause seizures. Infection can cause a seizure. A really high fever can cause a seizure. So if they have a seizure disorder, they'll end up on what's called an anti-epileptic medication. And that's going to be depending on the type of seizure that they have. But most of the time they respond well to anti-epileptics and they can lead a pretty normal life. There are some other categories of treatments, like some kids are on a ketogenic diet, or they have what's called a vagal nerve stimulator to help control their epilepsy. But most of the time kids respond to anti-epileptics. Does anyone know there's a common medication that is tested in nursing world? This is seizure medication that causes bleeding gums. Has anyone heard of this or had anyone talk about it before? So the medication is Dilantin, and it's also called phenytoin. It's a common anti-epileptic, and it causes hyperplasia of the gums and bleeding gums. So the treatment or the preventative care is to have parents massage the gums, and it can decrease the risk of bleeding. But it is a very commonly prescribed medication, and bleeding gums is not like a normal side effect. If you're having to like differentiate between different medications, sometimes it's better to like think about which side effect is not normal. So it's not normal to have bleeding gums, and Dilantin is probably it's the only medication that I can think of that the main side effect that you monitor for is bleeding gums. So if you're taking care of a kid that has a seizure disorder, there's certain things you always need to make sure you're doing. Make sure the side rails are up at the bed. You don't want them falling when they have a seizure. Make sure there's nothing, hard objects around the bed that they could hit when they have a seizure. For all patients, you want them to have their medical ID bracelet on, but if you have to give an emergency medication to a kid that's seizing, it would be really terrible if they didn't have their ID bracelet on. And make sure that you're teaching parents to supervise them when they're playing, avoid anything that triggers their seizure, and making sure the parents know the importance of taking their medication or compliance with medication. So there's another condition of childhood that's a neurological that's called cerebral palsy. Has anyone heard of cerebral palsy or known a kid that had CP? I think I saw you nod your head, Cassandra. Have you known anyone that had CP?
Yeah, isn't that the weakening of the muscles?
Yeah, so it's almost always caused by anoxic brain injury at birth. So they don't have enough
Mhm.
oxygen to their brain when they're being born. It can also be caused by like an intrauterine stroke or something happened that before they're born
I
that
think
causes
this
a lack of
person I
oxygen.
know, she had preeclampsia or something and delivered early, and the baby ended up having cerebral palsy.
Yeah, so that's not an uncommon,
Mhm.
and it's really sad because like, the baby's normal, doesn't have any
Yeah.
genetic problems, and then there's the complication of pregnancy and there's a lack of oxygen.
Because
to the
now they
baby.
think he's autistic and he's not meeting milestones and everything else now.
Yeah.
Sad.
Yeah. So if you're working in the world of pediatrics, you will undoubtedly take care of kids that have CP. And there's a wide range of symptoms. So they have the most common is that they're spastic. Their muscles are really tight, and they have decreased ability to move on their own. So a lot of them are wheelchair bound. Some of them have to use crutches. A common sign of CP is that when they're learning to walk, their feet aren't flat. They walk on their toes.
Are they kind of like
Um,
bow-legged a little bit too?
They can be a little bow-legged. A lot of kids are bow-legged though. So
Mhm.
bow-legged isn't necessarily CP, but walking on their toes
Yeah.
and not being able to kind of relax their muscles. Like I said, the most common form of CP is spastic CP. So there are different medications. So botulism toxin. So this is like the Botox that women get for wrinkles. They can actually use it for spasticity problems. And then levodopa, which is a medication they give to Parkinsonian patients, can also help with some CP. But mostly it's supportive care. There's no cure for it. So it's giving them like their adaptive devices that they need, making sure they have the mobility devices that they need. Some kids with CP can also have intellectual problems. So there's a term that you'll probably hear if you're working in a pediatric hospital, which is MRCP, mental retardation, cerebral palsy. I mean, people try not to use it because mental retardation is not the most socially acceptable word. But just thinking like if you've had lack of oxygen to your brain when you're born, you might have intellectual problems. So there's a wide range, and not all kids that have CP have intellectual problems, but they do go together. So, but always try to focus on what the kid is able to do. Like don't focus on the negative. And they have a ton of supportive devices out there to try to help these kids lead a normal life as possible. So, you could have a child with intellectual disability that has CP, and there could be it could be a genetic disorder, it could be Down syndrome, there could be all sorts of other things that cause intellectually impairment in children. So always remember that they have the same psychosocial needs, but they don't have the same ability to express themselves. So try to treat them as a human and don't focus on their disability, and recognize they might not have the same ability to express themselves, but try to use adaptive devices or communication aids so that they can communicate as much as possible. So we talked about Erickson's theory of development in the first section of class for like exam 1. And it's important that children have experiences that they can be successful in, so then they start to develop that sense of esteem, industry. They don't feel like they're inferior to other kids. So that's true even if they have disabilities or if they're intellectually impaired. So trying to like focus on what they can do and set them up for success, recognizing that they could be different. And just remembering a child who consistently fails at something can end up developing like a behavioral problem or be kind of angry or really affecting their self-esteem. So regardless of what's going on, as a pediatric nurse, you're going to always try to be doing family-centered care, individualizing the plan of care to your patient, making sure that you're trying to do as much of the home routine as possible, focusing on their development level, their maturity level, and trying to make it as, you know, the transition to life in the hospital as smooth as possible. And when you're working with kids that have special needs, always try to emphasize the strengths, you know, regardless of what's going on. They might be wheelchair bound, but darn it, if they aren't really good at learning the rules for board games, you know, whatever it is that they got, there's going to be something that they have that is one of their strengths, and try to focus on that. Really try to get them involved in as many community services as they need. Is there a school nurse? Is there like a support group for the family? Trying to get all of those connections in place, and being aware of what your resources are where you're working. So sometimes we think that we can kind of see, based on what the child looks like, their level of intelligence, or if they have any problem, in intellectual disability problem, and you really can't. Like sometimes kids like Down syndrome have like very characteristic facial features, and you're like, oh, that kid has Downs. But there can be other kids that have totally normal facial features and they have an intellectual disability, and then kids that are kind of funny looking that are smart. So don't ever assume that you know what sort of intellectual capabilities a kid has based on the facial features alone. So that is sort of the end of the conditions that kids can be born with or they can have. And we're going to move on to some like injury-related neurological problems. So kids can develop a concussion after they've had some sort of a fall or a sports injury. So you always worry more if the child doesn't remember the event. So if they come in a little bit confused and kind of sleepy and they don't remember falling, that's a more serious sign of maybe a fractured skull or more serious intracranial problems than just being a little bit nausea and foggy. So obviously if you fall and hit your head, you can have like a increased intracranial pressure from a head bleed, or you can have decreased oxygen delivery to your brain. So it's really important after they've had a head injury to do close monitoring. And it can take a little while for the problems to really be noted. So when you have a decreased oxygen level in your blood, overall you'll have increased blood flow to your brain, because your brain consumes a lot of oxygen. So if you don't have enough oxygen level in your blood, more blood will go to your brain to make up for the fact that there is oxygen missing from the blood. And that increased blood flow can cause cerebral edema, which then can cause increased intracranial pressure. So just to be aware that sometimes after a head injury, you can have signs of increased intracranial pressure a couple days later. So you need to make sure that parents need to know how long they need to be monitoring their child. So unfortunately, there is shaken baby syndrome, which is a form of child abuse. And this is, you know, generally speaking, the parent is over the top frustrated, you know, can't deal with the fact that the child is crying and picks the baby up and shakes the baby. So you think about like the brain being inside the skull, it can kind of move back and forth and it can cause brain damage. So you might see retinal hemorrhages. So you might actually see some blood in the eye. They can also just be like limp, drowsy, vomiting, not being able to breathe well. If they're old enough, they might be able to complain of a headache, and it can ultimately lead to death. So you know, just in general, to be aware when you're working in pediatrics, you always have to have in the back of your mind that child abuse is possible, and that you should be, you know, if a child comes in and something doesn't seem to add up, the story doesn't make sense, to kind of bring that child abuse thought farther up and do some more investigation. So when people have brain injury, sometimes they posture. So posturing is never a good sign. So if you have a patient that is either going like this with their arms, or their arms are straight and they're going out, both of those are posturing. So decorticate is coming in towards the core, and that's problem with the cervical spine. And then decerebrate is more problem with the midbrain. So this is going in is more of a spinal cord problem, and going out is more of a brain problem. But I remember it because corticate is towards the core of the body, and then the cerebrate is the other way, it's out. So posturing is never a good sign, and it can give you an indication of where there was an injury versus the brain or the spinal column, depending on how their arms are positioned for their posturing. So we've mentioned increased intracranial pressure a couple times. I just want to point out here in the corner, changes in vital signs. So I would definitely know this. This is your Cushing's triad. This is your increase in blood pressure, decrease in pulse, change in respiratory pattern, or irregular respiratory pattern. Other things that you might see if they have increased intracranial pressure are vomiting, impaired eye movements, being altered, decreased sensory motor function, complaints of a headache. But in terms of like, if you're monitoring vital signs, these three changes together are very concerning.
Which three did you say? I'm sorry.
Increase in blood pressure, a decrease in heart rate, and irregular respiratory rate. So, you know, if you ever are taking care of a child that's had a brain injury, nurses save lives. So just never underestimate yourself. Remember that you are the one at the bedside monitoring that kid. And so if you see something that's even a really subtle change, like at 2 p.m., they looked at you as soon as you walked into the room, and at 3 p.m., you had to go to their bedside and be like, hey, Helen, before they would look at you. That's a change, and you still need to report that. There's, you know, very, very small changes in how they're behaving can be an indication that something's going wrong, and also changes in their vital signs. So just always be aware of that, and making sure that you're having good communication with the rest of the healthcare team. So there's certain things that you need to, you know, be focusing on: level of consciousness, their cranial nerve response, you know, are their eyes moving? Are they smelling the same? Are they able to stick their tongue out? The posturing that we talked about, you know, we talked about the fixed dilated pupils as a very ominous sign. Bulging fontanelles, so you're not going to see that in a 4-year-old because their sutures are closed, but you can see it in an infant. The fontanelles could be an indication of increased intracranial pressure. Same with scalp vein distension. More ataxic spasticity in their lower extremities, or not having normal reflexes. So that's kind of the summary of like falling, having a brain injury. Kids can also have altered mental status after a near drowning event. So near drowning is the 4th leading cause of death in children under age 19. And near drowning is defined as survival beyond 24 hours. So I don't think that near drowning, so drowning is 4th leading cause of death in children under age 19. And near drowning is survival beyond 24 hours. So if you've had a child that was submerged in water, had a near drowning event, you're focused on hypoxia, so what their oxygenation level is, aspiration, they can have a lot of damage to their lungs, and then hypothermia, an inability to maintain their body temperature. And even if they survive, they can have permanent brain damage after a near drowning event. So it's defined just as submersion for more than 10 minutes with failure to regain consciousness within 24 hours. And then I'm sorry, so it's near drowning is submersion for more than 10 minutes, and it's ominous if they don't regain consciousness within 24 hours.
Is this something similar? I heard a story where like it was like 3 days later or something, the kid ended up dying, and like 3 days before that he had like a near drowning experience, and something to do with, it sounds similar to something like this.
Yes. So yeah, we talked about that whenever there's a brain injury, like the increase in intracranial pressure and changes can happen slowly over
Mhm.
time. So it's not always that they've had the near drowning or the concussion or whatever caused their brain damage and then they immediately had a problem. So it is possible that 2 to 3 days later, that's when you're going to see them really deteriorate.
Okay.
So thank you for participating and bringing that up. To kind of review this first chapter, we're going to do a quick Kahoot, and then you guys will take a break, and then we'll come back and we'll do chapter 24. And there's also Kahoot at the end of the chapter 24. So let me pull this up for you guys really quick. So it should load your game pin for you. Okay, so we'll go ahead and get started. So why are infants more susceptible to otitis media? The eustachian tube is short, straight, and wide. Infants are almost always lying down. They have increased susceptibility to upper respiratory infections, or sucking on a nipple creates middle ear pressure. Yeah, so their eustachian tube, I mean, a couple of the other options on there in terms of they are almost lying down, and they are more susceptible to upper respiratory infections because their immune system isn't quite the same as an older person. But the main reason is that eustachian tube is short, straight, and wide, so they don't really have the same ability to drain the fluid from their middle ear. So a student had a generalized seizure in the school nurse's office. At what point should the nurse call 911? The child is sleepy and lethargic after the seizure. The child vomited at the onset of the seizure lasts more than 5 minutes, or the child is confused and has slurred speech after the seizure. So yeah, the correct answer was the seizure lasts more than 5 minutes. The other options are something that is pretty common with seizures. You're going to expect seizures, expect them to be postictal, to be kind of sleepy and lethargic. They might be a little bit disoriented, have slurred speech, and it's not uncommon that they vomit at the onset. But if you're having a seizure that lasts more than 5 minutes, then you're really going to be worried about their airway. They might need intubation. This is progressing medications that are not going to be available at school. So this is the answer, that this is your emergency, that you need to make sure that you're calling 911. What would the nurse include in a teaching plan about the long-term administration of Dilantin or phenytoin? The medication should be given on an empty stomach. It can result in insomnia. Gums should be massaged to prevent hyperplasia, or the blood pressure should be closely monitored. Yeah, so this is that one where I told you this is the common seizure medication, and one of the side effects that's unusual, like you don't see this side effect with most medications, is that hyperplasia of the gums and the gum bleeding, and you do try to prevent that with massaging the gums. Which assessment finding in a child with meningitis should be reported immediately? A slight drop in blood pressure, irregular respirations, tachycardia, or an elevated temperature. Yeah, so several of you got that right. So we talked about Cushing's triad a couple times. So this is that irregular respiration. So what are the other two things that are part of Cushing's triad?
Blood pressure increasing and respiratory rate decreasing. I'm sorry, pulse decreasing.
All right, very good. Very, very nice. So yeah, you worry about the increase in blood pressure when it's associated with the drop in heart rate. Very nice. The nurse urges the mother of a 6-month-old child to get immunized against Hib vaccine. What is the Hib vaccine prevent? Does it prevent otitis media, protects against influenza, protects against bacterial meningitis, or protects against skin infections? So very good. Helps protect against meningitis. There's some protection against ear infections, but meningitis is a much more serious illness. So it's really important to get vaccinated against Hib to protect against meningitis. Which situation would cause the nurse to suspect a hearing impairment? 3-month-old with a positive startle reflex, an 18-month-old who speaks with 1-syllable words, a 15-month-old who is babbling, or a 24-month-old who communicates by pointing? So good. The 2-year-old, the 24-month-old that communicates by pointing, you should really expect your 2-year-old to be using 2-word sentences. They should be communicating verbally. Very nice. Marissa, you're on fire. So what is the best way for the nurse to communicate with a 10-year-old child who has a hearing impairment? Let the child's parents communicate for her, recognize that the child will communicate at a 6-year-old level, use gestures and signs as much as possible, or face the child and speak clearly in short sentences. Very nice. Yeah, so you don't want to use gestures and signs as much as possible. Like using a lot of gestures can make it harder for them to read your lips. So short sentences, looking them right in the eye, being at their eye level is the best way. What might the nurse explain as a common treatment for amblyopia? So using corticosteroids to treat inflammation of the optic nerve, patching the affective eye to allow the refractory muscles to rest, using glasses that will slightly blur the image for the good eye, or patching the good eye to force the brain to use the affected eye. Very good. So you patch the good eye and force the brain to use the affective eye. So what information should be given to parents to prevent Reye's syndrome? That they should have their child tested if the child has fever, vomiting, and lethargy, that they should use aspirin instead of Tylenol if the child has a viral illness, that they should get immunized against Reye's syndrome, or avoid using salicylate medication to a child who has viral symptoms. Yeah. So there isn't a test for ricin per se, but you prevent it by avoiding the salicylates, which the most common is aspirin. Very, very nice, y'all. Thanks for participating. So you can go ahead and take a 10-minute break and come back at 7. It'll be a 9-minute break. The next PowerPoint has a lot of slides. I'm just going to warn you, we're not going to get through all 70 slides, but I'll point out, information that is really important for you to know. And then we'll close the class with a quick Kahoot. And I just want to plug again that there's 2 review sessions this weekend, one on Saturday and one on Sunday. So I strongly encourage you guys to come to one of the review sessions for your exam next week. Okay. So I'll see you guys in 10 minutes.
Miss Rebecca. I don't know if she can hear me. Oh, she can't. Miss Rebecca. Friday is a holiday for the campus. We still on with you, right? And take our test with you.
Oh, which are you on the Centerville campus? Which campus are you on?
Norfolk. It's
Norfolk. What?
yeah. Isn't
Which
next
holiday is it?
the 11th is Veterans Day or something? I think the school's closed. Uh-huh.
Okay.
I'm
Thank you
just
for telling
asking.
me. Let me look.
I didn't know if
Yeah,
everybody was like that, if they school was closed for Veterans Day, but most Fortises I thought was closed for Veterans Day.
No, actually, only one or two of them are closed.
Oh, okay, maybe
I'm
because
so
we're
glad you on,
military
Darlene. I was
state.
like, oh no.
Yeah, no, that's
Okay.
why I sent out the email early on.
Okay.
that, the only holiday, well, we had a couple holidays this term.
Yes, ma'am.
Actually, the only holidays we have are Thanksgiving and the day after Thanksgiving.
Yes, ma'am.
Those are the only days that we are closed as a company, and all campuses are closed. Other
Okay.
campuses, there are some campuses will be celebrating Veterans Day.
Mhm.
Norfolk is one. I believe Pensacola does Veterans Day. And there might be one other one that does Veterans Day. So for those of you, we will have school. We will have
Okay.
class.
Okay, so be on
Because-
Zoom.
Yeah,
No
because
problem.
not all campuses celebrate or observe Veterans Day.
Yes, ma'am. Okay. Thank you so much, Ms.
Well,
Brown.
Yep, for those of you that have Veterans Day, that you are on, your campus celebrates Veterans Day, you'll have your option of a couple different things. You can make arrangements earlier in the week to take your exam on campus or with another class. You can come and take the exam with the class, or you can arrange with your instructor to take it at another time. But we want you to take it during that week. Okay?
Yes, ma'am.
So thank you for asking. I appreciate that you bringing that up with the rest of the students too. So I can also put an announcement up just to make sure everyone is clear about Veterans Day.
Yes, Ms. Rebecca.
And I
Okay.
see, yeah. So I see people coming back, turning their cameras on. Autumn, when you come back, could you please make sure your camera's on? So we're going to go ahead and start with chapter 24, which is the musculoskeletal chapter. Like I said, there's 70 slides in this PowerPoint, so we're not going to do all 70 of them, but I will make sure that I point out the good information or the necessary information that you really need to focus on, and then you have it as a resource to look at some more information. So kids are growing very fast. We've talked a lot about growth and development. So assessing their growth is really important because you do develop and grow quickly during childhood and adolescence. They actually have more resilient bones. So you think about an older adult, they're more likely to have osteoporosis, they're more likely to fracture a bone when they fall. But the bones of children tend to bend and they have more give before they actually break. Excuse me. They have a lot of blood supply to the bone, so they heal more quickly. So kids are less likely to fracture, and if they do have a fracture, they heal more quickly. There is this very specific part of the bone that you need to know, which is the epiphyseal plate. So this is where the growth plate is. So it's usually the head of the bone. It is the head of the bone, and if there is a fracture that occurs there, that can affect the ability of the bone to grow over time. So this is a more serious or more concerning fracture because it can affect the ability of the bone to grow over time. And if children have any sort of a deformity, you might see that when they're going through some sort of a rapid skeletal growth. So just being aware that their bones are different, they tend to heal faster, and they tend to break less easily. And this issue with if there's a fracture in that growth plate, that's something that's concerning. Can it affect the ability of the bone to grow over time? And we've talked a lot about milestones for sure. If you have a kid that's a year and a half, 18 months, and they haven't started to walk, that's something that really needs to be followed up on. They need to be evaluated. So they should be taking their first steps around a year. But if that hasn't happened, if they're not walking by 18 months, that is something that's very concerning. A lot of times parents have questions because kids don't walk like adults. You know, toddlers are kind of short and wide and kind of close to the ground. So they kind of waddle and they have this unstable gait, and that's normal. So sometimes parents will ask you about that. By the time they're a year and a half, they're not quite as wide. Their base narrows and their walk is more stable. And then by 4 years, they can hop. And by the time they're 6 years, they're really walking similar to an adult, and they kind of start swinging their arms. So sometimes parents will ask questions, thinking their kid looks like they're walking funny. And generally speaking, if it's not causing any pain or any problems, it'll get better over time. We talked about one particular problem that sometimes kids have that you need to follow up on. Do you remember what that is? It was like the way that kids that have CP walk. What do they do?
Walk on their toes.
They
On their
walk on their toes. Yeah. So even though kids, they progress through their walking ability, if you're looking at these kids in these pictures here, her foot's flat. They're not up on their toes. So their gait is going to change over time. It's going to get more adult-like. But if you see a kid who's walking on their toes, that's something that you need to pay attention to. And you're still going to be thinking about symmetry, strength, equal, it should be the same on both sides. When kids have a fall, but they don't have a fracture, then they would have what's called a soft tissue injury. And it's important to know this acronym, this rest, ice, compression, elevation. This is going to be, you're going to see this in med surg, you're going to see this throughout your life. This is the basic thing that you do if there's been a soft tissue injury. So soft tissue injuries include contusions, sprains, and strains. So contusion, where there's an injury and the blood capillaries rupture. A sprain is twisting of the ligaments causing pain and swelling. And then a strain is twisting of the tendons causing pain and swelling. So who knows? What does a ligament connect? Does that connect bone to bone or bone to muscle?
Is it bone to muscle?
On the muscle.
So the tendons are bone to muscle and the ligaments are bone to bone. So the difference between a sprain and a strain is going to be whether it's the tendons or the ligaments. So this is going to be the ligament here, so a bone to bone, and a strain is a bone muscle. But they both cause pain and swelling, and you're going to use the basic rest, ice, compression, elevation for both of them. So if a kid falls and has an injury, it's really important that you do treatment immediately, that you stop whatever's causing the pain, assess the situation, make sure there's something that needs to be addressed immediately, and then do the rest, ice, compression, elevation, teach about prevention, and always be thinking about safety with kids and anticipatory guidance. Was this a sports injury? How did this happen? Making sure they're using their appropriate sports equipment, etc. So this slide here goes over different types of fractures, and there's a couple that I really want to point out to you. So this spiral fracture, and it kind of shows you, it has the blue arrow. So this would be where you have a bone and it goes in two opposite directions, like it's spiraling this way. So this is the one that's most common with child abuse. So if you see this type of fracture, then this is going to be concerning for child abuse. A simple fracture, this one here, you see like the straight line, but the bone is still aligned. Whereas a compound fracture, the bone is broken and it's sticking out of the skin. And a green stick fracture, it's not a complete, it doesn't go all the way through. You can see the bone here on the bottom, and then there's the fracture here across the top. So this goes over, all of the different types of fractures. The ones that I think are the most common that you're gonna be seeing and thinking about will be the spiral, the compound, the simple, and the green stick. So, a fracture is breaking the bone and it's painful. You can have discoloration, limited movement, numbness may also appear. We talked briefly, they heal pretty quickly in children, generally speaking, but you do need to be worried about if it occurs in the growth plate because they can affect the growth of that bone. So when kids have fractures, they may end up in traction, and you do need to know which traction is used in which age and weight groups, and the basic nursing care of a patient that's in traction. So the first one we're going to talk about is Brian's traction. So this is going to be the kids under 30 pounds. These are your little kids. This is a kid that would be in Brian's traction. And it's for a fractured femur. And you can see, so the legs are straight in the air, and the buttocks, you can't really see it very well in the picture, but the butt is a little bit up off the bed. And the head of the bed can be a maximum of 20 degrees, and sometimes they can end up in a jacket restraint, so they can't pull at stuff, but you don't want them so restrained that they end up with like skin breakdown or any neurovascular problems. So regardless of what type of traction, we're going to get into a couple different types of traction. There are certain things that you're going to be doing as a nurse. So you want to make sure you're doing range of motion exercises on the unaffected limb. You want to make sure that the bone is aligned the way it's supposed to be, that you're monitoring for complications. If they're old enough, you should have a trapeze. Like, you're not going to put a trapeze in a 2-year-old bed, but they should have a trapeze so they can reposition themselves in the bed. They're at risk for urinary retention, and because of the fact that they're lying in bed, they're at risk for respiratory complications and circulatory complications. So circulatory complications, like they're at risk for clot formation. They could develop a DVT, something similar that you would see in like a med-surg post-op patient. So older kids, so Bryant's traction is the kids that are under 30 pounds. Older kids can be in Buck's traction. And this is a picture of Buck's traction here, where it pulls in 2 directions to align the bone. So it pulls the hip and leg into extension. And this is the same thing where they can't have their head of the bed elevated. So they should never be in high Fowlers. It's the maximum of 20 degrees. And being in traction helps reduces the pain and muscle spasm. And we're going to talk later, there's a condition called slipped capital femoral epiphyses, and you can use this traction for that condition in children. And then Russell traction is very similar to Buck. So it's the same thing where it's used in the older kids. And then we talk frequently about what you need to monitor for. So who has heard of compartment syndrome, or what sorts of things do you think about when a child or a patient might have compartment syndrome? What do you monitor for? What is compartment syndrome? You guys talked about it in med search? I'm asking you because it's something you're going to monitor for similar things when you have a patient that's in traction.
Is it like if they don't have circulation after like a break or something?
Okay. So how are you going to monitor for circulation for a leg that's in traction? What are you going to look for in the patient?
Like capillary refill?
Capillary refill. Very good.
Yeah,
what else are you going to look
sensation.
for?
Like if they can feel
Coldness.
like sensation.
Yeah.
Yeah. Do they have normal sensation? Are they able to move their toes? What type of temperature should the foot be if the leg's in traction? Should be warm. What would worry you? What would you see in a patient and be like, that's not normal? I need to call the doctor. Cold.
Purple.
What else? Purple.
Pale.
How about the cap refill? How long, at what point would you be like, that's a sign of bad perfusion?
More
It
than
should
10
be
seconds.
like less than 3, isn't it? Or less than 2 seconds?
So 2 to 3 seconds is normal. So if it's beyond 3 seconds, then you're worried about perfusion. So yeah, 10 seconds, you would definitely be worried, but even if it's 3 to 4 seconds, and this is one of those things as a nurse, so you're going to be paying attention, like you go in, it was 2 to 3, okay. And then you come the next time, you're like, no, I think it's 3 to 4. That's a subtle change that you really need to pay attention to, because it's an indication that the perfusion is getting worse. So sometimes kids can end up being in traction for a long time. It's not always like 48 hours. They go to the OR and they get their surgical repair and then they're out of traction. So if they are in traction for a long time, they are, at risk for other complications just because of their prolonged immobility. So, they are going to need to have those those, I think they're called SCDs, the stockings they put on their legs that squeeze that help to prevent the blood clots, to help prevent DVTs. They're at risk for tissue breakdown. They're at risk for atelectasis and pneumonia because they're not having the same lung expansion. They can have decreased appetite. They're not having, they're not up moving around. They can get constipated. They can have urinary retention. Over time, they can have muscle wasting. So I kind of feel like this, a pediatric patient it's been in traction for a long time is going to be kind of similar to the patients you're going to see in an adult med surg unit. And all of those things that you're going to worry about in a post-operative adult patient, you're going to worry about in this sort of pediatric patient also. And it's just all related to prolonged immobility. So what sorts of things are you going to do to help this patient not have complications? Talked
Would
about
be-
the squeezer, the SCDs. What else are you going to do?
Encourage activity in all other limbs.
Yeah, so you're going to be encouraging range of motion in the other extremities. What about their lungs? What are you going to do if they're lying around in bed and they can't, and they're at risk for atelectasis? How are you going to help prevent them from developing
Incentive
atelectasis?
spirometer. Would you use that?
Incentive spirometer. How about for the constipation?
Increase fluids.
Increased fluids. They might end up being on laxatives, or they might need like Metamucil or something that gives them extra fiber. Very good. So there's certain things that you should be paying attention to when your patient's in traction. So, that it's aligned the way that the traction is supposed to align the bone. The bed's not more than 20 degrees, so they should never be in high Fowler. The feet they should always be elevated. So they should never be resting on the side of the bed. If they're in the Bryant's traction, their buttocks should be elevated up off the bed. You're doing the range of motion. You're thinking about things like, preventing DVTs. You're doing the neurovascular checks, which you guys did a great job with that in terms of the perfusion, the pulses, the color, the cap refill, making sure that you're monitoring the skin integrity. Obviously, they broke a bone. They need to make sure you're staying on top of their pain and preventing constipation. And if they're old enough, they have a trapeze, so they can reposition themselves. That's going to help with the skin breakdown if they're able to kind of wiggle around in the bed. Okay. So sometimes when kids, break a bone, if they don't end up in traction, they'll end up with a cast. So what are some things that you teach parents if the child has a cast on? What are some things that parents need to know?
Not to stick anything in it.
Not to stick
And don't
anything
get
in
it
it.
wet.
Don't what?
Don't get it wet.
Don't get it wet. Very good. And
Use
they
cold
should
air.
still be use cold air. Very good. And they should still be taught to do the same sort of perfusion checks that you're going to be doing as a nurse at home. Obviously, parents are not nurses, but they should be looking at the color of the, if it's the arm, looking at the color of the fingers, the swelling of the fingers, the perfusion, are they warm, is cold, etc. Very, very nice. You guys are doing a great job. So kids can get an infection sometimes when they've had an injury. And sometimes there's just like bacteria in the blood that colonizes in the bone. So it's called osteomyelitis. So it can be preceded by a local injury, but it doesn't have to be. Sometimes it happens in the absence of an injury. And it's bacterial, and it's bacterial infection in the bone marrow. So one of the main things that I think that you need to remember about osteomyelitis is that it takes a long time to treat. So these kids are going to be on antibiotics for 6 weeks. They almost always get a PICC line or some sort of a permanent line, and they will end up being discharged home on antibiotics. And this is one of those things that you're just going to need to kind of prepare the parents that it's a really long treatment, and they can be uncomfortable and in pain for quite a bit of time, even after they've started the treatment. So the things that you kind of do as a nurse, you kind of make sure they're getting their diagnostic workup done that they need. Like I said, it's usually 6 weeks of IV antibiotics, and it's definitely IV antibiotics. They're not taking oral antibiotics. Making sure you're staying on top of pain relief and making sure that you've got child life or whatever else you need to be involved so that you're making the hospital stay as good as it can be for the child. So osteomyelitis is an infection that kids can have. There's a muscular problem that is a genetic condition that, children aren't necessarily diagnosed at birth. They're usually diagnosed at the time that they're starting to walk or a little bit later. So it's the muscular dystrophies, there's Duchenne's and Becker's. They present very similarly, but Becker's tends to be less severe. And then and the other is Duchenne's, and they're both forms of muscular dystrophy. Like I said, they're usually diagnosed around the time kids are starting to walk. So it says here 2 to 6. My experience has been a little bit on the younger, not age 6, but when they're not, you're going to notice that they're clumsy, they're not walking normally, and you're going to start to wonder what's going on. So this is picture of this kid here. This is Gower's maneuver. So this is a kid with muscular dystrophy, and this is how he would try to get up off the floor. Like, they don't have the same control muscle strength, so they have a hard time going from the floor to standing. So this is kind of what they would look like as they're trying to get up off the floor. So they have frequent falling. They're kind of clumsy. It is frequently associated with intellectual impairment, but it doesn't have to be. And there's no cure. So patients that have muscular dystrophy, they'll end up with a definitive diagnosis, but it's just supportive care. There isn't anything you can do to kind of reverse the changes associated with the muscular dystrophy. So it's all going to be about making sure they have mobility devices that they need. And then since they don't have the same ability, they're at risk for respiratory infections. It's not uncommon that they're on like CPAP and BiPAP at night. And they can also develop cardiomyopathies. So it's just kind of treating all of the problems associated with their lack of mobility. And then obviously, they can have intellectual impairment, but they almost always are able to walk and talk and engage. So it's not uncommon that they're very depressed. They're not able to do the things that other kids are able to do. So a social work or a psychology consult is often needed. So this is the one that it was kind of briefly mentioned when we talked about traction. So the slip femoral capital epiphyses. So it's displacement of the epiphysis of the femur, so the head of the femur. And it normally occurs during growth spurts. And so they have pain, there's a limp, they can't bear weight on the involved leg, and they can put them in traction to pull it back into place. But even if they use the traction, they can still require surgery to permanently put it back into place. And leg calf perthes is another condition of the bones of adolescence. And it involves the head of the femur, and there's inadequate blood supply, but it's something that kind of occurs spontaneously and almost always just gets better on its own spontaneously. So this is not somebody that's going to go into the hospital and get traction if they develop it. They're going to have pain, they're going to be uncomfortable, but it's not going to require traction, and it normally gets better on its own. Having said that, because there is decreased blood flow to the head of the femur, they can end up with problems long-term, where they end up maybe even needing a joint replacement later in life if they have this condition when they're in their adolescence. So this one is, they're going to be limping, they have limitations on their movement, but like I said, it almost goes away on its own without any treatment, but they do need to be monitored because they could end up with joint problems. You can end up needing this joint replacement surgery. So there's a couple of different bone cancers. So there's the osteosarcoma, and the other one is Ewing sarcoma, but the first one is osteosarcoma. And then this one has a high rate of metastasis. Does anyone know what it means if the cancer has a high rate of metastasis? What does that mean?
Like it multiplies.
Yeah, it multiplies and it goes to other places in the body.
Yes.
So the most common place for the osteosarcoma to spread in the body is to the lungs. So you start out with a cancer in the bone, and then you end up with lung cancer, but the original cancer came from the bone. So this is going to be confirmed by a biopsy. It's normal that they will have pain and swelling, and they might have a fracture. So the treatment is going to be, unfortunately, resection or amputation of the limb that has the tumor. And has anyone heard of phantom limb pain?
Yeah,
What does it mean if you have, what does
where
that
you
mean?
have where you have pain where you don't have a limb, right?
Yeah, so your leg, like you have a tumor in your leg and you have your leg amputated right
Mhm.
above the knee, but you still feel like you have pain there even though the leg's been amputated. So the other bone cancer is the Ewing sarcoma. This one is more responsive to radiation and chemotherapy, so you're not necessarily going to need to have an amputation. It is also possible to have metastasis, and if that happens, the prognosis is poor. And it's the same if it goes somewhere else. The first place it usually goes is the lungs. So we think about arthritis being a older adult problem, but children can have what's called juvenile idiopathic arthritis, which used to be called juvenile rheumatoid arthritis. Those are the same. Sometimes you'll see both of those acronyms. So it is a systemic inflammatory disease that involves the joints, the connective tissue, and there's not a specific test. It's kind of a diagnosis of exclusion. They try to figure out what's going on and nothing else is the answer. And they were like, okay, it's juvenile rheumatoid arthritis or idiopathic arthritis. If they have symptoms that last more than 6 weeks, you really need to get them evaluated. It is kind of on the autoimmune spectrum, so it's not uncommon that kids that have GIA, they have waxing and waning symptoms. They'll have like an exacerbation, their symptoms will get better, and then they'll get worse a few months later. And it's broken down into 3 different subcategories. So when there's a high fever associated with it, it's acute febrile or systemic. It's polyauricular if I think it's 4 or more joints involved, and parauricular if it's less than 4. It might be 5 though. So it's broken down by, is it associated with acute fever, and is it, the number of joints that are involved. And it's not uncommon, especially when they have the high fever, that they often have abdominal pain and vomiting, and you're going to expect to see elevated C-reactive protein and erythrocyte sedimentation rate, which is the ESR. Those are just markers of inflammation, and you expect to see that when they have the juvenile arthritis. So you treat juvenile arthritis by treating the symptoms. So they might end up with like corticosteroid therapy to help the inflammation. You try to control the fever. You can do warm packs. And you want to try to promote like as normal growth and development and normal function as possible. But it is on the autoimmune spectrum. So it is common that they're going to end up at least intermittently on steroids to kind of tamper down the immune system when they're having an exacerbation. So, just kind of prepare the family that it doesn't just go away. It will have these periods of remission where it comes back. And so you're going to try to focus on the positive, help them as much as possible, and try to let them realize that that it does have these exacerbations. So they should be expecting that they're going to have periods of time where they're feeling worse. So something that you are going to be monitoring for if you're working in an outpatient setting is scoliosis. So has anyone ever known someone that had scoliosis or had to wear a brace for scoliosis? Nobody? Were you screened for scoliosis when you were a child in the clinic?
I know.
Yeah.
I know some people.
Yeah. So did they have a brace? Did they have surgery? What did they have?
Brace.
Brace. So this one on the I guess it's the right, where you have the like the S-shaped curvature here. This is the scoliosis, and you can see her shoulders and her hips are also uneven. So this is the lateral curvature of the spine is the scoliosis. And it's more common in girls than in boys. If it's functional, then it's just caused by poor posture, but it can also be structural. And then that will cause changes in the vertebrae, and they may need intervention. So scoliosis is graded based on the curvature. So if it's up to 20 degrees, so less 20 degrees or less would be considered mild, and that's just physical therapy and exercise. And then 20 to 40 degrees, they're going to have to wear a brace, and then over 40 degrees, that requires surgical intervention, and they have what's called spinal fusion surgery. So as a nurse, one of the things, you're going to be monitoring for scoliosis. So what do you think you're going to see? Like if you're checking for scoliosis in an outpatient clinic,
Poor
what are you
posture.
going to look for? Yeah. How do you normally assess for it? What do you ask the
Them
patients
to
to do?
bend
What do you look for?
forward, I think it is.
Uh-huh. Yeah. You
You'll
have
see,
them
like, a
lift their
curve.
shirt up, and you have them reach towards their toes. And then you look for that curvature of the spine, and you're going to also be paying attention to their hips and their shoulders. So, we're talking now, we're in the school age years with kids, so they're at risk for sports related injuries. We talked about the different soft tissue injuries, and doing the RICE. Just being aware that these sorts of injuries can happen to kids, especially if they're playing sports. One of the things that you do as a nurse is you really try to make sure they're having the right protective equipment. If they have an injury, they're getting care right away, and they're getting the appropriate care. So unfortunately, when we work in pediatrics, we always have to have in our brain, on the back of our brain somewhere, that there's a risk for child abuse or family violence, domestic violence. So does anyone know, as a nurse, are you a mandatory reporter? Are you required to report suspected child abuse?
Yes.
Yes.
Are, and you need to know the states where every state will have slightly different rules, but in all 50 states, you are a mandatory reporter. So there are some things that can trigger child abuse, social stress, the family doesn't have the financial resources that they need, or just kind of a dysfunctional family unit. Parental stress, low self-esteem, uneducated, substance abuse, things can trigger it. And then, children that are disabled have, psychological problems, behavioral problems, that are hyperactive, or kids in foster care, stepchildren are also at greater risk. And having said all that, I just want to really point out that there really isn't, a social class or anything like that really where child abuse always happens. Like someone could be poor, uneducated, having a really hard time paying the rent and getting food on the table, and they never abuse their kid. And someone could have all the resources in the world, tons of money, all the education, and they could be abusive. So even though there are risk factors, I just really want to emphasize that don't ever categorize anybody that's in any category of a socioeconomic state and assume that they're not treating their child well, because that's absolutely not true. It's more that there are stressors that can predispose, but anyone in any social class could be an abuser. So you shouldn't, make any generalizations based on how somebody dresses or their level of education or their access to financial resources. So child abuse can take many different forms, straight out emotional abuse where you're not seeing anything physical, sexual abuse, physical abuse, and there can also be neglect. So both are things that you need to be aware of and that you're monitoring for, and you're still going to need to report. So, if you make a report in good faith, you're a mandatory reporter, but anyone who makes a report in good faith is not going to be prosecuted. So, but you still should know what your laws are for reporting. So, if you're in a situation where you're dealing with child abuse, you can support the child in other ways other than just reporting it. So making sure that children have like access to therapy and social work, that they have some sort of an avenue to express their feelings, help them develop problem solving skills. Obviously, you want your child taken out of the abusive situation and in a safe situation, but even having said all that, there are things that you can do to help the child deal with the fact that they've been in an abusive situation. There are certain things that you're going to look for. So these are bruises all over the child's body, retinal hemorrhages, seeing the blood spots in the eye, any irritation in the genital area. And I would say always believe a child who says that he or she has been abused. Never assume that a child would make that up or is lying. And this next one here is really hard for me to look at. But one of the main things that we talk about in child abuse is having bruises in various stages of healing. So you could fall down and you could bruise your legs, your butt, and your upper back. Okay, because you fell all the way down, flight of stairs. All of your bruises should look about the same. So if you're having bruises where like some are red and purple and some are brown and some are yellow, that's an indication of child abuse, because this is an indication the child's been bruised on multiple occasions. So it's also, even though you're keeping child abuse in the forefront of your mind and you're monitoring for it and you know that you're a mandatory reporter, there are some cultural practices that can be interpreted as physical abuse. So one that I'm familiar with is like a healing technique called cupping, where they put cups on your back to try to release toxins, and it could leave the cup marks on your back. Well, if you don't know what that is, that could look like abuse. So just to be aware of different practices that your patients that you're taking care of might practice, and ask, have open dialogue and ask, and don't assume that everything is abuse, and be aware of different things that might present like abuse, but you need to investigate further. So that is kind of the highlights of this very long PowerPoint. I'm going to pull up the Kahoot for you guys. And then if you have any questions, we can have a little bit of time to answer questions at the end. We'll go ahead and get started here.
Ms. Brunel, can you wait for me? Oh, never mind.
Oh,
I had
Oh.
just joined back. My phone went dead. It's okay.
I'm so sorry. What intervention will the nurse caring for a child in buckskin traction implement? Assist the child to be pulled up in bed, maintain the child's feet against the foot of the bed, keep the child's heel on the bed surface, or keep the child in high Fowler's position. Right. So this is the one that you want to help them pull them up in bed. You don't want them in high Fowler's. It's a maximum of 20. So whoever wanted to join, you can join now. The pin is 827-2387. I'll give you a second.
I'm sorry. Can you say it again? You said
Sure. It's
827.
6pm-8pm. Were you able to get in?
Yes, I'm in.
All right. So what is normal capillary refill? 4 seconds, 6 seconds, 5 seconds, or 3 seconds? Very good. So 2 to 3 seconds. If it's longer than 3 seconds, that's delayed and it's a sign of bad perfusion. What finding would the nurse assessing the neurovascular status of a child in Russell's traction report immediately? Capillary refill less than 3 seconds, ability to wiggle toes, skin that's warm to the touch, or bluish coloration of the skin. Very good. So this is the one that you're worried about. They should be able to wiggle their toes. You don't want them to have decreased movement of their toes. So you would be worried about their perfusion if they had the bluish coloration of their skin. Which observation would lead the nurse to consider child abuse when a child is being evaluated after falling down the stairs? The mother is very anxious. The child has red, green, and yellow bruises. The child broke his arm last year and for the mother is accident prone, or the bruises are noted on his head, arms, and legs. Very good. So, the bruises in various stages of healing, this is a sign of child abuse. Maybe you should make a note. Mom says he's accident prone. Sometimes kids are accident prone and they fall a lot. So, but this is the one for sure. Bruises in multiple stages of healing is a red flag for child abuse. What would the nurse consider an abnormal finding on a musculoskeletal assessment of a 4-year-old child? Appears to have flat feet, walks on his toes, swings his arms when walking, or has inward turned knees when standing. Yeah, so walks on the toes, this is the one that's concerning for CP. Kids will have that inward turning of their knees and then their legs will straighten out as they get older. But walking on the toes is concerning for potentially CP. What nursing action will significantly decrease the risk of serious complication for a child in Bryant's traction? The child's buttocks are resting on the bed, neurovascular checks are done frequently, the bandages are wrapped tightly, or the child is restrained and unable to wiggle or move. Yeah, so the best way to prevent complication is your close monitoring. So this is your neurovascular checks, and we talked about the pulses, the perfusion, the color, all of that. So you do want them to wiggle a little bit. We talked about if they're old enough, they should have a trapeze bar to help reposition themselves. And their buttocks shouldn't be on the bed, especially if they're in the Bryant's traction, and the kids that have the legs that are straight up in the air, you're going to kind of pull their butt up off the bed. And you don't want them wrapped so tightly that they have any problems with their circulation to the extremity. So a nurse cares for a child in Buck's traction. Which observation requires an immediate nursing intervention? The ropes are on pulleys, the head of the bed is elevated to 20 degrees, the child's heel is placed firmly against the foot of the bed, or the weights are hanging freely. Right, so as the heels placed firmly against the bed, you don't want that. So whatever the extremity is in traction, the heel should be elevated. And if so, the rest of these things are all things that are should, like the rope should be on pulleys, the weight should be free flowing, and the head of the bed should be a maximum of 20 degrees. So a child with juvenile rheumatoid arthritis, which is also called JIA, has swollen knees and ankles at temp of 38.8 and abdominal pain. What type of juvenile arthritis is that? Common, systemic, chronic, or psoriatic? Yeah, so this is the one when you have the fever and the abdominal pain. So anything that's like systemic is like full body, thinking about not just the joints, but something else going on. So systemic is also called acute febrile. So Bryant's traction is reserved for children who weigh less than 30 pounds. Is that true or false? So that's true. That's the one where the kid's legs are up in the air and you want the buttocks just a little bit off the bed. Okay, last one. What should the nurse include in parent education about the long-term effects of a leg Kath-Perthes disease? Degenerative arthritis may develop later in life. The disease is self-limited and requires no long-term management. There are no long-term effects, or there's a risk of osteogenic sarcoma in adulthood. Yeah, so very good. So this is the one where they can maybe potentially end up needing a joint replacement later in life. They can have degenerative arthritis. It is self-limited, but there is the possibility of a long-term complication. So that's why this is not the best answer. It's one of those kind of tricky nursing questions because it is a self-limiting. Most children get over it fine and they don't have any long-term complications, but it is possible. And since the question puts in here about the long-term effects, you should really be focusing on the long-term effects. So good job for those of you that got that right. Ooh, I love the new Halloween themes. I hope they keep something up for the next after Halloween's coming on. Ooh, right, Samaya, good job. Okay, so that is the end of class. Does anyone have any questions that they want to bring up or any concerns before we wrap up? Okay, several of you have met with me. I want you to always remember, the best thing to do is send me a message in Canvas and let me know if you want to meet. A couple of you have met with me over math. I have some additional math worksheets. So whatever your concern is, I want you to let me know if you want to meet. And I strongly encourage you to go to a review this week. There's one on Saturday and Sunday. And unless you have any questions, I'll go ahead and let you guys go for the night. All right. Have a good week. I'll post an announcement about Veterans Day, but everyone, I hope you have a good weekend. Bye-bye.